Good morning, everyone. Today I will discuss the topic transforming apogeotropic posterior semicircular canalolithiasis with definite treatment recommendations. Specifically, I will discuss three clinical cases of apogeotropic posterior semicircular canal benign paroxysmal positional vertigo, a relatively rare but clinically important variant of the posterior canal BPPV. Benign paroxysmal positional vertigo, abbreviated as BPPV, is one of the most common vestibular disorders. It is typically caused by otoconia dislodged into the semicircular canals. The otoconia consist of calcium carbonate crystals that inappropriately enter and stimulate the semicircular canals. The posterior semicircular canal is most frequently involved in the classic geotropic form of posterior canal BPPV. The Dix-Hallpike maneuver elicits characteristic ipsitorsional nystagmus beating towards the lowermost affected ear in the Dix-Hallpike position. This nystagmus has a latency, follows a crescendo-decrescendo pattern, and demonstrates fatigability. In contrast, the apogeotropic variant of the posterior semicircular canal BPPV is atypical. It is thought to occur when otoconia are located in the non-ampullary distal arm of the posterior semicircular canal, producing an inhibitory response during the Dix-Hallpike testing. This results in diagnostic oculomotor findings of downbeating torsional positional nystagmus during positional testing, such as the Dix-Hallpike maneuver on either side, with the torsional component beating away from the affected ear. The nystagmus is often of a lower intensity, more persistent, shows less fatigability, and can sometimes be provoked bilaterally. These features make it challenging to differentiate it from the anterior canal BPPV. In this presentation, I will highlight the key diagnostic oculomotor responses observed in these three cases and demonstrate practical techniques to transform apogeotropic variant into the more typical geotropic forms or other treatable canal variants. Once converted, patients can benefit from well established canal repositioning maneuvers such as Apple or Buffone maneuver, which carry strong evidence-based recommendations from the American Academy of Otolaryngology, Head, Neck and Surgery, the AAOHNS. The AAOHNS clinical practice guidelines strongly recommend diagnosing posterior canal BPPV on characteristic nystagmus during the Dix-Hallpike test and treating it promptly with canalolith repositioning maneuvers as first-line therapy. These approaches are highly effective, non-invasive, and provide rapid symptom relief while avoiding unnecessary medications or imaging in the uncomplicated cases. Through these cases, we will explore transformation strategies such as reverse Semont maneuver, bascule maneuver, and head hyperextension that help move the otoconia into more favorable position, enabling the definitive treatment. This not only improves the patient outcomes but also highlights the importance of precise diagnosis in managing complex or refractory BPPV variants. Thank you. I look forward to diving into these case details and welcoming your questions in the comment box. So we start here with our title slide, transforming apogeotropic posterior semicircular canal BPPV into variants with geotropic torsion. This is how the animation shows the otoconia in the non-ampullary arm near the crus commune. The aim is to move this otoconia from this location into the periampullary location, resulting in typical periampullary posterior semicircular canalolithiasis with geotropic torsion. In the recent years, there has been some doubts about the position of otoconia in the apogeotropic forms of posterior semicircular canal BPPV. The apogeotropic posterior semicircular canal BPPV was supposed to result from the otoconia possibly jammed in the non-ampullary arm near the crus commune, and this was hypothesized by Agus in year 1995 and later detailed by Paolo Venucci in 2015. However, in recent years, there have been some confusion and additions to the location of the otoconia. In the year 2021 and 2025, Luigi Califano from Italy proposed that An apogeotropic form of posterior semicircular canal BPPV could also result from a periampullary variant, may not be exactly periampullary, some distance away from the ampulla of posterior semicircular canal, which causes the downbeat nystagmus and which can be easily converted into the typical variant by repeated hyperextension and flexion of the cervical spine. So we have a patient of this variant also in our present talk, and in recent years, in 2020, Shigeno found a variant where the nystagmus was non-persistent, that is lasting less than 60 seconds, and it was of downbeat and torsion towards the non-affected side, but there was a reversal nystagmus also. So we have this case also. So case 1 is a around 67-year-old male patient came with a history of positionally triggered vertigo for past 5 to 7 days. The left Dix-Hallpike test shows a left torsional downbeat positional nystagmus. So we have to look and see how long this nystagmus lasts. So if it is persistent, then it is likely to be apogeotropic posterior semicircular canalolithiasis of the right side, because it is torsionally beating to the patient's left and it has a slow crescendo-decrescendo character, which is a peculiar feature of the inhibitory nystagmus arising from right posterior semicircular canal. In this case, so we waited for full 1 minute for this nystagmus. Indeed, this is a semi-paroxysmal nystagmus with slow crescendo-decrescendo pattern. We need to look into the presence or absence of reversal nystagmus. Once we have observed the oculomotor responses during the left Dix-Hallpike test, which is ongoing right now. So sitting from the left Dix-Hallpike position did not evoke any reversal nystagmus. We waited for around 30 seconds to look for reversal of the nystagmus and we could not find any. In the FAB 2026, Giacinto Esprella Libonetti from Matera, Italy, published a paper on reverse Simond maneuver or the pendular maneuver, the reverse Simond and Simond maneuver done in succession for 1 or 2 times, and they convert the apogeotropic posterior semicircular canal BPPV into the posterior semicircular canal BPPV with geotropic torsion. Because the torsional component was towards the left side, we chose to do the reverse Simond maneuver towards starting from the nose down position to his left side. So this is the reverse Simond maneuver. The first position is like demi-Simond. The face is rotated 45 degrees to the patient's right and is taken to the nose down position. To his left non-involved side, and then taken to the nose up position to the right, and there you see that this converts into the upbeating right torsional positional nystagmus. So there is an intracanalar migration of the otoconial debris from the non-ampullary region to the periampullary location. This we treated with the apply maneuver and the patient responded in less than 24 hours of his suffering which were present for past 5 to 7 days. So how do the reverse Simon maneuver works? This is the position of this female sitting in short sitting position, and here the otoconal debris is here in the non-ambulatory arm. I have animated this. In the nose down position, it is actually expected to move into the otoconia because this is one of the methods to do the demi-Simon maneuver. However, the position of the otoconia may be such that, or the inertial forces generated by the otoconia itself and the endolymph may push it towards the ampulla, and if it occurs like that, it can geotropize, leading to the movement of the debris in the periampullary location, and exactly this happened in this case. Case 2 is a 63-year-old male patient came with the history of vertigo for past 10 days. The right Dix-Hallpike test showed a slow crescendo-decrescendo semicircular left torsional positional nystagmus. Characteristic appear to be of Apogeotropic Posterior Canal BPPV resulting from right-sided non-ampullary posterior semicircular canalolithiasis. But this time we tried a repeat Dix-Hallpike test with neck hyperextension, and this we tried because the nystagmus that you just now saw was non-persistent, and in fact we had a success. Repeating the right Dix-Hallpike test with neck extended about 40 degree evokes upbeating right torsional typical crescendo-decrescendo positional nystagmus. So there is an intracanalar migration of the debris either from the non-ampullary arm, but as the Califano pointed out in year 2021 and again in 2025, this could in fact be periampullary located where the otoconal debris first moved towards the ampulla ampulopetally, resulting in an nystagmus that was left torsional and downbeating and slow crescendo decrescendo. And as we hyperextended the neck, and then we before that we carried out the patient to the sitting position again, the otoconia moved towards the periampullary location, and this we treated with the apply maneuver and the patient responded in less than 24 hours. So this is the present situation. The otoconal debris, it was thought to be here by the Agus in 1995 and Vanucci in 2015, and there used to be a possible canal jam. This was proposed by Califano in 2021 and 2025 that it could be periampullary slightly away from the ampulla, which converts into the typical variant by hyperextension and flexion of the neck carried out successively. And this is 2021-20 Shigano variant, where the nystagmus has typical character of the less than 60 seconds duration and has a reversal nystagmus also. So neck hyperextension leads to geotropization because the debris is here in the position A. As the patient is taken to the Dix-Hallpike position, the otoconal debris moves ampulopetally, resulting in an inhibitory downbeat positional nystagmus. And as the patient's neck is flexed and then hyperextended, the movement occurs ampulofugally, resulting in the typical periampullary posterior semicircular canalolithiasis, resulting in excitatory upbeating ipsitorsional positional nystagmus. Case 3 is a female around 53-year-old came with the history of vertigo for past 3 days. Right Dix-Hallpike test shows a left torsional downbeat positional nystagmus. Importantly, this nystagmus was non-persistent, lasted less than 60 seconds, and it was indeed and has to be slow crescendo-decrescendo semi-paroxysmal because this is an inhibitory nystagmus generated by the otoconia and the right posterior semicircular canal in the non-ampullary arm, possibly without a canal jam. It was just impacted, not causing a jam in the non-ampullary arm. And indeed, there was a reversal nystagmus also in this case, which I have not shown here in this presentation. The left Dix-Hallpike test was also done in this patient. That also shows a non-persistent, slow crescendo-decrescendo semi-paroxysmal left torsional downbeating positional nystagmus. We chose to carry out a bascule maneuver. The bascule maneuver in this case would mean a nose down position to her left and a nose up position to her right because the torsional component was towards her left side. This is the short sitting with the head rotated 45-degree to her left, that is the non-involved side. And we carried out the bascule maneuver. We kept this nose down position for 15 seconds and then transitioned her to right lateral recumbent with nose up. In fact, the bascule maneuver was initially reported by me under the leadership of Andrea Castellucci from Italy for the posterior semicircular cupulolithiasis in August 2025. However, it has been found lately to be useful in atypical variants of the posterior semicircular canal BPPV like the Apogeotropic Posterior Semicircular Canal BPPV of the Vanucci and Agus type and also in the Shigano variant of the posterior semicircular canal BPPV. Other possible indications are short-term posterior semicircular canalolithiasis, which is not amenable to the bow and yaw or our adapted prone pitch and yaw maneuver. So we carried out the nose up position to the right and nose down position to the left in succession 5 times on each side. And we waited for geotropization to occur, but in this case apparently geotropization to the posterior semicircular canalolithiasis did not occur during the maneuver itself. There is a slight difference between the maneuver suggested by Giacinto Asprilla Lebonati in Fab 2026 published paper. He although says that that is a bascule maneuver is in fact a pendular maneuver or a reverse Simon maneuver and then a Simon maneuver done 1 to 2 times. But here we do it in repeated succession. In such patients, there is always a possibility of vegetative changes like vomiting. And in fact, because we are using a breast maneuver multiple times, there are always chances of getting it switched to another canal. So we should be ready, and the patient should be made aware of that possibility. Many of the cases that we first reported for vesical maneuver, they got converted into the geotropic forms of the horizontal canal BPPV by the movement of the otoconal debris, which was possibly adherent on the short arm side of the posterior semicircular canal into the utricle, from where it entered the horizontal semicircular canals along posterior arm. So we now just retested the patient with the right Dix-Hallpike testing after the vesicular maneuver. And to our surprise, we saw a geotropic horizontal positional nystagmus. The otoconal debris has moved from the non-ampullary location into the utricle, and therein and therein after it went through into the long posterior arm of the right horizontal semicircular canal. This we confirmed by the supine node test also. However, she was treated actively with the Guffoni maneuver and she responded to it. So these are the some of the three techniques where I've been able to successfully convert the apogeotropic form of the posterior semicircular canal BPPV either into the posterior semicircular canal with geotropic torsion. First case by the reverse Simon maneuver, and second case by the head upper extension, and this case by the vesicle maneuver. The vesicle maneuver in fact resulted in canal switch to a variant which has got a very good success rate with the Guffoni maneuver. So I finish my talk here. Thank you very much.